Okay, we'll go ahead and get started. Again, this is the Dementia and Antipsychotics in a Long-Term Care Setting Quality Improvement Initiative, a partnership between Vanderbilt Medical Center, Vanderbilt Center for Quality Aging, and Q-Source. You have made it to Session 5, Implementation of Behavioral Strategies and the Management of Pharmacological Interventions. And you can see the title for our final session next month. If you missed any of the previous sessions or would like to go back to review them, you can find those on our website. And Britt should be feeding that to you in the chat pane right now. If you have questions or comments for our presenters today, please use the chat function. Your chat pane should either be on the right-hand side of your screen or at the top of your screen. And to verify that everybody knows how to use the chat pane, go ahead and send us your facility name and how many people are currently viewing the webinar. While you're doing that, I'll remind you that links, again, to the previous presentations are on the website, but we have also updated and added the case example from Session 4 that was presented as part of the Q&A. The Iowa ADAPT tools we talked about in Session 4, which we'll review again today, and a couple of evidence-based practice links that came out of our other presentation of Session 5, including Consult Jerry RN and the Nursing Home Toolkit link. So all of that is available, and I'll remind you that again at the end. So this is Session 5, Implementation of Behavioral Strategies, and we have Jim Powers, and actually we have Jennifer Kim's colleague, Carrie, with us today, and you've heard her before. They will be covering this information, and I'm going to turn it over to them.
Thanks. So just touching base on what the objectives are for today, we are going to be looking at implementing a behavioral care plan, and we've got a couple of examples on how to do that. And then while we're discussing this particular case study, talk about reviewing the Iowa ADAPT Step 2, and then moving on to discussing Step 3, where we actually monitor outcomes and based on those outcomes, how we might adjust course if we see or don't see success with our initial intervention. And then we'll have a brief Q&A session. And then Dr. Powers is going to touch also on some pharmacological approaches in those patients who perhaps are not responding fully to behavioral intervention. All right. And so last month we identified and described the problem behavior as well as testing.
Sorry, we're back. We had a little technical difficulty.
Okay, so in a review session 4, we identified and described different problem behaviors in patients with dementia and how to assess these patients and potentially develop some treatment plans for them. Okay. And as you can see here in this slide, in terms of selecting and applying the intervention, you're really looking at making sure that you're choosing interventions that are appropriate for your particular facility in terms of staffing, in terms of the preferences of the actual patient and family, and the available resources that you have. You're going to develop that plan and make sure to have a team-based approach in this process. And it's caregiver approach is going to be the key component of this process. And adapt or change the actual environment, whether that be within the room or the facility for this particular patient. So looking at actually evidence-based interventions, let me move to the next page here. These are some examples that we've pulled out. So, for example, with a patient who has agitation or is irritable, some of the possible options in terms of working with them in a non-pharmacological manner is to either redirect or distract them. If they have particular activities that they enjoy engaging in, for example, I know that I've had a patient who I noticed was very agitated and would be picking up the covers or their clothing, and we actually had the nursing staff provide them with a stack of washcloths that they would actually fold and unfold. And that sort of, even that simple process, sort of tactile process, redirected their agitation. For patients that are able, certainly physical exercise is a great opportunity to get them out walking in the hallway or taking them outside even. For patients who are wandering and either restless or bored, you can certainly look at trying to engage them in social activities that are available. Have rest stations along the way if they're pacing, just to make sure that they actually have the option of sitting down when they need to. And again, taking them outside is an excellent opportunity if that's a possibility. And then certainly when you have patients who are resistant to care, whether that be bathing, clothing, feeding, et cetera, looking at changing the staff approach to bathing, and I think Dr. Powers touched base on that in our last session, doing a bed bath when appropriate versus actually taking them to the shower as an example. So we have one case study, and my colleague, Dr. Kim, this is actually a patient of hers that she had at one of our local long-term care facilities. The patient's name was Mary. And she was a female nursing home resident who was admitted with late-stage dementia. The family had been keeping her at home and trying to maintain her there as long as possible, but she had become pretty difficult with a lot of disruptive behaviors, and so the family was feeling overwhelmed and concerned about her overall safety, and so she was admitted. And in the actual long-term care setting, the behaviors that were causing some problems is that she was constantly trying to get up unassisted from her wheelchair and out of bed at night. And this is a patient who did not have a stable gait and was definitely a fall risk. And so when the staff would come and try and get her back into bed or in her wheelchair, she would get very agitated and mildly combative with the staff. In terms of how often this was happening approximately 5 days a week, so pretty frequently. In terms of duration, it was 2 to 3 minutes typically that they were having to try and get her calmed down. And it was considered intensity-wise moderately disruptive. In particular, the concerns were that it was a possible safety risk for this patient as well as the staff who were trying to assist her back into her chair or her bed. And you can see here, as we discussed at the last session, this is using that worksheet in identifying what the actual behavior is and the problem is, and then looking at how often is this happening, how long is it going on, and to what degree is it disrupting or possibly causing problems for the patient or the staff in terms of safety. In terms of what was potentially triggering this, Dr. Kim sat down with the staff and also with the family and discussed this particular patient, and the staff felt that part of what was triggering these problems is that the patient was bored and depressed and feeling pretty isolated. She also, from a physiologic perspective, had pretty poor vision. She had macular degeneration and was hard of hearing. There was also a question as to whether or not part of this might be triggered with her having some urinary urgency, and that she just wasn't, because of her dementia, wasn't able to express the actual cause of her agitation and trying to get out of bed. Dr. Kim noted that the family in particular said that this patient had historically been a very social person, and always sort of wanted to be where the action was, where the activities were. When she was in the home setting, she sort of had this shadowing behavior where she would want to be in the same room, in the same location where her caregiver was. not necessarily because she was anxious, which sometimes that can be a cause, but because she sort of wanted to be there and be interacting with people. The staff also noted during this case discussion, this family discussion, that the patient was very tactile, focused on what she could touch and feel, and very curious, and some of her behavior also seemed to be triggered by this sort of curiosity and wanting to sort of know what was going on. So in terms of the intervention, what they came up with was doing an assessment. Physical therapy actually did a thorough assessment of her and decided that she was actually appropriate for a Mary Walker, which would then allow her to safely ambulate and walk around the facility without having that increased risk of falling and harming herself. So we have our first polling question.
A resident with dementia may get agitated when asked to perform a task that has many steps. True or false? And then make sure you hit the submit button after you answer.
Okay.
All right, everyone who answered got it correct. So true, a resident with dementia may get agitated when asked to perform a task that has many steps. And our second polling question, effective management of agitation in a patient with dementia may include all the following non-pharmacological interventions except reorientation and reassurance, physical restraint, structured activities, modifying the environment. So select your answer and hit the submit button. So it looks like everyone selected physical restraint, which is the correct answer.
And one of the things that I did want to note is that technically, according to CMS guidelines, the Mary Walker can be considered an actual physical restraint. And so one of the things that Dr. Kim wanted to clarify in the last session, and then she asked me to make sure we talked about in this session, is that as long as you're very careful about your documentation, have that it's an appropriate device for her to be able to be mobile and walk around, and that this is part of the process of getting her safely ambulating, that this shouldn't be an issue. Yeah. Okay. So one of the challenges that everybody faces, whether it's in the hospital setting, the long-term care setting, or even primary care setting, is how do you go about training staff when you're trying to integrate a new approach to patient interactions and also integrating changes in how we interact with the patient. The challenges oftentimes are who do we include and how do we go about doing these trainings in a way that's effective and actually can instigate change in the facility. So one of the things that I've seen that I certainly would highlight is that it's very important to make sure that you get all the appropriate staff involved. Who is the person that is going to be delivering care at the bedside for this patient, and not just limited to your nursing staff, but your CNAs, your physical and occupational therapists, the nursing staff, anybody who is having any kind of interaction with this patient really does play a role in helping integrate new non-pharmacological interventions at a facility. It's also really important to make sure that this is information that's given to everybody regardless of what shift. Because certainly one of the most effective ways of managing these behaviors is to make sure that it's a reinforced process, regardless of shift, morning, afternoon, or in the wee hours of the night. And so part of the process would be looking at who's going to be involved, making sure it's tracking each shift, and then doing an educational needs assessment. Who potentially is going to need to learn more about how to do non-pharmacological management of dementia, or when to have a CNA come and talk to the nurse about particular behaviors that may be demonstrating an increase in agitation, things like that. Find out what the staff really knows about dementia and the related sensory changes of aging and how those might trigger agitation, anxiety, etc. It's also great, I think, no matter what setting you're in, to identify staff leaders, or a lot of times we use the term champions, people who are going to sort of lead the charge in the education of their fellow staff members and also the PDSA cycle in general. People who are enthusiastic and wanting to have those conversations in the hallways, in the lunchroom, in various places, to sort of reinforce whatever is being done in the actual education session itself. It's really important, as I said earlier, to incorporate the staff ideas and input. I know that certainly in the hospital and long-term care setting, my bedside nurses and care partners and CNAs are the people who know the patient really well. They're there on the ground and see what's going on. It's important to get them involved in the actual discussion. Deciding what types of educational materials that you want to integrate into your training, whether it's going to be actual handouts, or is it going to be a group discussion, case study group discussion. And then there's always the option of doing online modules. It's certainly a cost-effective way of doing education, but certainly I think the in-person education tends to be a little bit more engaging regardless, and I say that as an educator. And then in terms of training, I think it's really important to start small. That's really the key in a PDSA cycle anyway. Choose one floor or one unit, your dementia unit, for example, and integrate this education into that particular group of staff training sessions and see how it goes. And then once you've actually sort of, quote unquote, worked the bugs out, then consider moving to other floors and growing your particular training. Also, the last comment there, target specific problematic issues. I think you also get a lot more staff buy-in if you actually are making your education focusing on problems that they specifically are seeing. So it's relevant to them and not just sort of a broad brushstroke generalized education process. And then the last thing to consider, of course, and this is true regardless of your work setting, but if you have a high turnover rate, then it's important to make sure that any new staff who are brought on are also going through this training. And, that also helps reinforce the process for the staff that are still there. And then there's the trick of balancing out and making sure that you're not having in-services every day, which can cause fatigue. And so being sort of savvy as to how to schedule these in-services. And then, really also being aware that it's very difficult to change habits. I mean, we know this as healthcare providers when we tell people they need to go and exercise or change their diet or make behaviors. We're asking people to change habits that are not necessarily easy to change. And so being aware of this and not getting frustrated is change is slow. When you have difficult patients who are taking up a lot of time and energy, emotional energy and physical energy, oftentimes it can be very discouraging for staff. And so also being aware and compassionate in terms of staff fatigue in that situation. Also really having to be, this is more just a logistical concern when you are doing staff training, you need to make sure that you've got sufficient coverage. And then also, certainly it's something that we see at Vanderbilt because it's a very large institution. Oftentimes there's many different people doing different projects. And so you can also get some fatigue that way. when you have staff thinking, oh, here's yet another thing that I have to do or change. And so really trying to be smart in terms of planning out your PDSA cycles so that you don't have people thinking, oh, here's another one. So just really something to think about all of these particular questions is, how will you improve staff buy-in? Because at the end of the day, that's going to be the most important part of this whole process.
This is Jim Powers, and we're going to now switch to a real authentic example where we were asked to be consultants for a 100-bed facility. And this involves looking at the results, so monitoring outcomes, and so it's a good example of step 3 of the algorithm that we've been discussing. This facility faced a 25% antipsychotic prescribing prevalence, and they received benchmark reporting showing that they were at the 30th percentile compared to regional peer facilities. Looking very bad, and the administration said we have to do something. We recommended an in-service educational intervention. It was designed with the goal of increasing staff awareness and knowledge of non-pharmacologic interventions for managing disruptive behaviors, but also improving communication between patients and staff about these behaviors and providing staff with additional tools for managing these behaviors to ensure that their efforts were recognized. Very much like the program that we're presenting to you today. We developed 9 20-minute sessions to encompass all the units and all of the shifts. And the in-services emphasized that most behavioral disturbances are provoked by interactions with caregivers, and that patients with dementia have a very limited ability to change their behaviors. Thus, any change must come from us as caregivers. So behavioral strategies and environmental changes were discussed, with the participants encouraged to bring up actual cases from their experiences, their challenges, but also their successes. And talking about staff buy-in, they were very eager to show us their patients, and that was really the way that we engaged the staff. They did not want to be lectured. We knew that. But come here, see what you'll do with this patient. See if you have any bright ideas. They loved that. It became a stump the chump, and we enjoyed it too. The staff perception of the program effectiveness, barriers to change, and monthly review of quality indicators such as falls, restraint use, and of course antipsychotic prevalence were tracked. And over a 6-month period, antipsychotics prevalence actually did decline to 18%, which put them in the 90th percentile ranked with their peers. But we also found that there were many spillover effects, many positive effects to this intervention. For instance, a 20% reduction in the proportion of patients taking 9 or more medications. So they were reviewing all of the medicines in addition to the antipsychotics. We also found that there was a decline in the proportion of patients who fell. In fact, 23% fewer falls, which was sustained over a 6-month period. The staff reported that the program was well received. We did ask them about barriers to change. The progression of dementia in several patients was an issue. Occasionally, there was reduced staffing levels, which led to problems with communication between oncoming shifts and implementing behavioral treatment plans. And occasionally, there were problems with families who felt that if patients were well controlled on their current antipsychotics, why change them? So they had to be educated as well. So monitoring outcomes and adjusting the course as needed was important, particularly in the cases of those patients where those barriers were encountered. And they developed treatment plans, corrections to treatment plans, amendments to them, and we're very proud of their outcome because in many cases they were able to reduce and sometimes eliminate antipsychotic medications. So step 3 is quite complex, but allows you to adjust your target for a better result. So track behaviors using a rating scale, such as the tool that we have provided for you, the ADAPT program, the worksheet to document the frequency, duration, and intensity of behavioral disturbances. And look and see if the frequency and intensity of the behavior might give you some clues as to how to intervene to treat the contributing factors, be it physical, environmental, psychological, or psychiatric. Make sure that you have the adequate dose of the intervention. In other words, as you saw, patients that are demented find it difficult to follow many step commands or to go through a lot of complex recommended strategies. So have things simple-minded, tailored to the patient, and we find that is much more effective. We have to ensure that staff completely understand the treatment plan and that the shifts talk to each other, that there's good communication, particularly around the problem of patients. And then, of course, adapt and add newer interventions as needed, or perhaps as new information is provided by family members, other shifts, or perhaps the patient themselves. We find that the sheet also will help you in terms of passing on information to other shifts. For instance, the intensity scale should be helpful to ongoing shifts. Some of the behaviors may not have much effect on others, but some may be very disruptive. And in particular, those triggers for those behaviors should be passed on to other shifts. And because improving the safety for all is most important. Patient assaults, patient on staff assaults become sentinel events, and it's important to mitigate that risk as much as possible. And how consistently are the staff applying the appropriate intervention? The behavioral approach is also important, and this is part of an ongoing quality improvement project that you may all wish to adopt. The behavior itself is important, but also how consistently does the staff apply the intervention, and do you have to modify it when it's no longer effective? Make sure that all of the staff on the team are cooperating together, and that the individual involved, to the extent that it's possible to explain to the patient, understands the program. It may be a behavior modification program that involves reassessing, restating, reinforcing the information to the patient. This might be privileges such as smoking behavior. It might be time that they can do enjoyable activities. It may be favorite foods. Whatever the treat, whatever the reward, make sure that they understand the reasons for that and be consistent in applying it. We find, too, that as staff turnover, as staff shifts change, as the patients change, that the continuous staff development has to be done in order to keep an active non-pharmacologic treatment plan always first in mind when approaching difficult behaviors. Not everything works the first time, and we find that different shifts may actually use different interventions and be able to educate ongoing care of the patient and inform improved interventions by collaborating with their various strategies, but also the results of their different interventions.
Okay. So going back to our original case with Mary, with Mary Walker, she was actually able to be much more social, and what the staff noted is that the long-term outcome was that she had a reduction in the frequency of her agitated state. It went down from, I think we said 5 times a week down to 1 to 2 times a week. The duration was still the same, about 2 to 3 minutes, but that the intensity of it also had improved, that there was really a minimal effect on the patient and others, meaning staff. Another happy coinciding side effect of this particular intervention was that they were able to decrease the dose of PRN clomiphen that she's been given for her agitation. And then also, she was sleeping better at night, requiring fewer PRN doses of trazodone, and also that she had no falls. So in terms of the safety of her using that Mary Walker, it was really great to be able to also see that that was also, we were keeping her safe. So when the group, the team, sat down and looked at this improvement, they decided at that time that they were going to continue the use of the Mary Walker with Mary. And there was the consideration because she was, already had advanced dementia and obviously was going to continue to decline in terms of her cognitive status. There was a consideration of possibly moving her to the dementia unit. So that she also was able to have access to the small group of stimulation activities. And so that was part of the discussion in terms of when do we do this, when would it be appropriate and most helpful for her. Okay, so again, just to reinforce, it's really important to make sure that all of this work that is being done by the team is being documented appropriately. In particular, it's really helpful to make sure so that other staff, when they come in, can see these particular non-pharmacological interventions, what was effective, and what didn't help, what did work. This also gives you an opportunity to really be able to compare outcomes. So again, I know we keep sort of talking about this particular worksheet, but really it is an effective way to actually quantify these changes that you're seeing. And so rather than just sort of going by, not hearsay per se, but just, report from one person to the other, to actually have it written down and documented that you're seeing this decreased frequency and decreased intensity is really of benefit.
And there's time for another polling question. A one-time training in non-pharmacological interventions is adequate for staff. So we can get our WebEx post to post the question. There we go. And select your answer and hit the submit button. Okay, and everybody answered false, which is correct.
That is the correct answer, and I'll just emphasize that we are asked many times to provide this training over and over again in the long-term care setting as well as in the acute hospital setting, and it's amazing how much we learn every time we present it to new staff, but how important it is to keep a constant presence of these ideas in front of the staff so that they have the most flexibility in terms of dealing with these very difficult behaviors that we all face.
Before we move on to managing pharmacological approaches, we'll take a little time for Q&A. So if you have questions about the non-pharmacological interventions, please send those through the chat pane to Britt. And I'll remind you, we had a really good question from a facility during session 4, and that response is posted on our website, as well as the links to Nursing Home Toolkit and Consulting Jerry RN, which are some other excellent evidence-based practice resources.
All right, we also would appreciate your success stories. If you've tried an intervention that has been very helpful for a problem behavior, tell us about that. We would love to share that with others.
And you'll be able to find, like I said, all these resources on our website, which will be active for the next 6 to 12 months. Okay. No questions? We'll go on to managing pharmacological approaches.
We realize that even when you adhere to all the principles that we have been presenting to you, problem behaviors can continue. In my experience, however, the non-pharmacologic approach can work in more than 50% of cases. When you do consider antipsychotics, they should be considered after attempting the non-pharmacological approaches that we have mentioned, the steps to identify, assess and treat the contributing factors, select and apply non-drug interventions, monitor outcomes, and adjust the course as needed. If you will do that, you will find the need for antipsychotics will be at least half of what it might have been if you just reach for the drugs first. For persistent and severe cases, they may be indicated, and for specific diagnosis, CMS indicates that there are 10 diagnoses for which they feel that the use of antipsychotics is indicated. And these are bipolar disorder, schizophrenia, the treatment of treatment-resistant depression, autism, Tourette syndrome, mania, and schizoaffective disorders. Beyond that, realize that we are using antipsychotics in an off-label fashion. So when we treat agitation and dementia, that is not one of the conditions that was listed. Treatment with an antipsychotic should require objective documentation. Which behavior requires the intervention? Is this behavior permanent or transitory? Has the behavior been evaluated for possible contributing factors that could be treated by addressing these inciting events as opposed to using a medication? Have you ruled out environmental causes and also medical causes? Realize that delirium, acute change in mental status, can be precipitated by medical illness, pain, surgical emergency. Are you using these agents for persistent symptoms? And are they not caused by preventable reasons? And are there organic mental symptoms with associated psychotic or agitated behaviors? In other words, psychiatric diagnoses. Our psychiatric colleagues have presented to you earlier in this series about the medications and their potential side effects. And we know that CMS requires that we try a gradual reduction of these agents if they are started at least every 6 months, unless the patient has one of the previously mentioned organic symptoms that we talked about. And there should be evidence in the record that at least in the last year that there have been 2 previous attempts to reduce the dose to the lowest level to control symptoms, and to document the ongoing need and justification for the medication with the diagnosis, the symptoms that are being addressed, and the consideration of other treatments in a risk-benefit analysis. We realize that one of the barriers to antipsychotic reduction and elimination can be family reluctance to change. And it's important to educate the family as to the potential side effects of these medications. And we also find that new staff, frustrated staff, overworked staff, also need to be supported as well, because it is very, very difficult to care for these patients in on an ongoing way, and it's very tempting to reach for medication to control behaviors.
So we've come to our last polling question. A resident with past history of agitation and breaking out was controlled on olanzapine 5 milligrams twice daily. The dose had not been changed for the previous 6 months, although he had exhibited no outbursts during that time. The family is reluctant to consider any medication changes. Which is the best approach? A, respect the family wishes and leave the dosage unchanged. B, respect staff concerns for safety and leave the antipsychotic dose unchanged. Or C, educate family and staff regarding person-centered care and medication safety and initiate an antipsychotic dose reduction plan with frequent review of outcomes. So select the best answer and hit submit. Okay, and everyone selected C, educate family and staff regarding person-centered care. Good job. We've had a lot of correct answers today. I will give you a little hint of what is to come in session 6, and that we will be talking about some of these barriers, in particular the barrier of family and staff to change. So you can look forward to that next time.
All right. We're going to go into the case series here that we've received and talk about several individuals for whom the use of medications was initiated. And again, these are examples, and you may have patients very similar to this. We'd love to hear from you. Let me start out with this one. Help me, help me, help me. This is a patient with a mood disorder with dementia of Alzheimer's type. He had psychosis, including hallucinations, as well as an overwhelming anxiety. This patient had increased anxiety and was yelling, was inconsolable. Non-pharmacologic measures were tried. The family was supported. Reassurance was provided to the patient. Validation and reorientation attempted, distraction, and trying to reapproach the patient. Unfortunately, the patient continued to yell out and was not able to be helped with these measures. Current medications included trazodone, Zoloft, Aricept, Namenda, and Nuedexta. The psychiatric nurse practitioner who was involved with the case had just recently increased clonazepam the previous week. On review, there did not appear to be any physical symptoms that appeared to be causing this escalation of behavior. Medical problems were thought about. A urinalysis, a blood count did not suggest infection. The psychiatric exam was conducted, which suggested uncontrollable agitation. The recommended plan with psychiatric consultation was to increase the clonazepam dosage and to continue non-pharmacological measures and social support. Over time, and it took several weeks, there was a modification of the behaviors, but again, this required the use of medications, but there was a great understanding on the part of all concerned about the importance of continued non-pharmacologic measures to help maintain a quality of life and comfort level for this individual. The next case is one of physical aggression. This was an individual who had a history of dementia with sexual acting out behaviors, also anxiety and a mood disorder. There were some other medical conditions, concomitant medical conditions, hypertension, COPD, congestive heart failure, and diabetes. This individual had a physical altercation with a female resident during an argument. Staff witnessed this and quickly intervened. There were no significant injuries. This individual was receiving Paxil, Seroquel, Tegretol, Lorazepam Aricept, and medroxyprogesterone. Reviewing the case, the medical problems appeared to be stable. There was no change in the blood pressure, the respiratory situation, or the diabetic control. All pertinent medications were given appropriately, and behavior modification measures were instituted to calmly approach the individual, provide emotional support, confront inappropriate behaviors and redirect, but also to provide verbal praise for appropriate behavior. The plan here was to continue all medications without increase, and also to continue behavior modification measures and visits by the mental health team with psychotherapy as appropriate. And again, this was a way to de-escalate the behavior and to try to avoid contact between the two individuals who did have an altercation. And again, an appropriate addition of medications or continuation of medications where dose reduction would not be appropriate in this case. Time permits, and I did want to go over one of the challenging cases that was presented in session 4. This was a case that we had reviewed by one of our nursing home medical directors and by our consulting geropsychiatrist, Dr. Taylor. The case was presented and it came to us through the chat pane. We have an extremely difficult resident that we have not been able to manage. She becomes extremely anxious as soon as she awakens. By lunchtime, the anxiety begins to increase, and she remains that way until she goes to sleep around 10 p.m. She has been treated in several different inpatient psychiatric centers to no avail. She appears to be in a constant panic and perseverates on dying, going to hell. She cannot be redirected by staff or family, and there appear to be no triggers or distractions. She has continuous rocking motions that do not appear to be an akathisia, and she is currently taking diazepam, 10 milligrams 3 times a day on a PRN basis, lorazepam, 1 milligram every 6 hours on a PRN basis, Namenda, 10 milligrams twice daily, mirtazapine, 15 milligrams at night, olanzapine, 10 milligrams at night, then Lafaxine, 150 milligrams daily, Ambien, 10 milligrams at night. Now she's losing weight as a result of being too anxious, and she's not eating. Would love some advice. Our consultants reviewed this, and I'll give you their responses. It's difficult to provide good advice for someone who is so persistently ill despite several recent inpatient hospitalizations. However, there are a few things to consider. First, it's worth considering the diagnosis. This tends to be far more severe than we see with most anxiety disorders. Is she psychotic? Have we evaluated for metabolic disorders such as hypothyroidism or chronic pain and shortness of breath? The described focus on dying and going to hell may represent underlying delusions or perhaps other psychotic symptoms. She might respond to spiritual care or even be more appropriate for hospice or palliative care. The anxiety might be secondary to the underlying paranoia or delusion. If this is the case, the use of most of these agents that were detailed would not be expected to provide much benefit, and attention should focus on antipsychotic medications, realizing that a higher dose of olanzapine, if her hepatic and renal function permit, or transition to another agent may be needed. If she's not psychotic and it is purely anxiety, then the focus should remain on serotonin or serotonin norepinephrine medications. The treatment of anxiety often requires high doses of these medications, and one might consider titrating the Effexor to a maximum dose, again, if hepatic and renal function permit, up to 225 or 300 milligrams a day. Alternatively, you could work towards the maximum dose of other agents, such as fluoxetine or duloxetine. It's also possible that she could be having an unexpected reaction to the benzodiazepines. She appears to be on 2 different benzodiazepines plus Ambien. We would encourage simplifying that regimen to a single agent. Once psychosis is ruled out and you're working on getting her to a higher dose of an SSRI, she may need a benzodiazepine. For anxiety, at least for the moment, as she is persistently highly anxious, it might make more sense to give her regularly scheduled doses rather than PRN doses. And these could be titrated at different times to provide better round-the-clock coverage. However, you should make sure that she's not overly sedated. You should monitor for falls risks and watch for disinhibition or paradoxical worsening of symptoms that can be seen with benzodiazepines in demented patients. Wow, that was a case. I hope that's helpful to those that submitted. Not seeing the patient makes it more difficult. But again, we invite your contributions, again, your challenges and your successes.
Okay, and so just to wrap things up, we've sort of walked through over the last several sessions how to, using the ILO app tool, to walk through the identifying the particular problematic behavior, assessing for possible underlying causes of that behavior, looking at unmet physical needs, psychological needs, environmental causes, or possible underlying psychiatric issues. Looking at how best to treat any of the contributing factors if any of those have been identified as problematic. And then looking at selecting and applying a non-drug or non-pharmacological intervention. And certainly that is something that will be guided by what is specific for that patient, what may be effective for the patient, and also what is the staff and the facility able to do. And then step 3 is looking at actual monitoring of the outcomes of those non-pharmacological interventions, seeing if they have worked or not, and if not, how can we potentially adjust those particular interventions for a better outcome.
So session 6 will be next month, our final session, addressing barriers to change from the perspective of psychiatry, nursing, and medical directors. Again, we'll have a morning and an afternoon session, and we will have a combination of presenters from each of those disciplines. We also, concurrent with this webinar series, have done focus groups with some local Middle Tennessee facilities, and the staff there have provided us with a wealth of information, but also identified several barriers to change in terms of reducing antipsychotic medications and implementing behavioral care plans that they have faced, and so we'll have our expert panel address those as well as their barriers they have experienced. If you have cases or concerns, challenges you've had in implementing care plans, we invite you to send those to either Britt or I and we will certainly get our experts to address them. If we can get WebEx to post the final evaluation question, make sure you fill that out before you log off. Excellent. And again, there's our contact information. And make sure to fill out or complete the evaluation question before you log off. And if nobody has any questions, we'll see you back in March for our final session.